So let's look a little more at that association of transfusion with mortality. The Rao group at Duke took advantage of the fact that there were these huge databases that had been created when the studies were done in patients with acute coronary syndrome, looking to see which clot-busting recipe worked best. You can imagine that when the direct thrombin inhibitors and all those came on and became part of what was available to them to treat these patients, that there had to be large studies to see what was the preferred mix, what you use first, what you use second, et cetera, what the predictors are. So they had huge international studies with a ton of information about each of the participants already recorded, and they accessed those databases to ask some very simple questions. So these are patients now with acute coronary syndrome, so they're coming in tipping like, I'm trying hard to have an MI, right? They looked at what was the nadir hemoglobin, how did that relate to the transfusion volume, how many of these patients went on to have a frank infarction, and how many of them died. They adjusted their findings for, again, the things that they thought would affect those outcomes, baseline characteristics of the patient, the state of their disease, the treatments that they'd had, sex, weight, race, a whole family of cofactors. And after doing so, what they found was that, let's look at the transfused and not transfused here. The nadir hemoglobin in the transfused was 29.0. So that tells you in this huge study, again, 29,000 patients, that everyone was pretty much still practicing 1030. They were a little tiny bit below it, but they were essentially practicing a 1030 objective. Does anybody know where that came from, the magic, keep them at 10 grams per deciliter and 30%? You've all heard that, right? Any idea where it came from? Or what decade it came from? It came from the 1940s in an opinion paper. It wasn't a study. Nobody tried some patients at one and tried other patients at a different and said these patients did better. It was an opinion paper by some anesthesiologists that's what they usually do, is keep their patients 1030. And so here we are 60 years later, and we're still talking about 1030 as if it ever meant anything. It was never an endpoint of a study. There's no science behind that being where you want a patient to be. In fact, the science about where you want your patients to be is what we're going to dig through right now. That's what's coming forth right now in the last decade, finally defining the role of transfusion and pointing to a number of things that are real eye-openers. So with that little bit of commentary, their nadir hemoglobins for those who were transfused was only 29, so they didn't let them get very anemic. Look at the difference in the MI rates and the difference in the death rates. People who were transfused, they were older, they were more often women, they were more often black. They had a lower median body weight, and they had more comorbidities. So it was very important that they had done the adjusted analysis for all of those cofactors. While we're looking at this description in the context of this study, does anyone have an idea of why people who are transfused are more often female or more often black? Because that's a repeating theme in these studies. Pretty much, whatever cohort you go into, you're going to find that the women get transfused more than the men do. Any ideas? Surely you have some. Who's more likely to be iron deficient? Okay, so there's one for you. Maybe more of them come in with lower hemoglobins because they're iron deficient, and so they end up getting transfused because they're anemic to begin with. Sickle cell? Well, that would be the same for blacks and Caucasians, and thalassemia as well. So hemoglobinopathies are more common in the black population. And so if you're ever looking at epidemiologic data that tells you what the distribution of hemoglobin is in that population, you have to be sure that they've excluded those that have hemoglobinopathies like alpha thalassemia, sickle cell traits, C disease, etc. Any other ideas about why women would get transfused more? I'll tell you part of the answer anyway. It probably is all of the answer. If you look at the distribution of hemoglobin in men and women and Caucasians and non-Caucasians, they don't overlap. If iron replete, everything normal, no hemoglobinopathy, got everything you need, this is where I set my hemoglobin. Women are about 1 gram per deciliter shifted from their male counterparts. and blacks are about half a gram per deciliter shifted. So if you line them up, it goes Caucasian males, black males, Caucasian females, black females. And that's the normal distribution. So if you think simplistically, like any patient that goes below, 8.5, it will be transfused, then the odds are very much higher that someone who has a normal distribution curve that's closer to 8.5 will get transfused. So women get transfused because people use a very simple cutoff that's really designed for Caucasian males to define anemia that, because of their shift in hemoglobin, has them meet that particular cutoff a lot sooner in their blood loss. Does that make sense?
It's not an actual, it's a relative because of the dilutional effect. Is that not correct? In women as opposed to men, more dilution.
You mean when they're having cardiac surgery?
Because they're a gram lower.
No, that's the actual distribution. That's the actual normal, when they do the NANE study, this is from the National Health and Nutrition 3. I forget what the E stands for, evaluation study, yeah. The government goes out every few years to many tens of thousands of people in the general population and obtains information about their health, their diet. They do a lot of testing, they do a lot of measuring, and they come back with data that you can use to establish the normal range for things. And it's from that information that you see that women naturally belong to the side of the male counterparts in terms of their hemoglobin distribution. When I was in medical school, what I was taught was women who go for heart surgery do worse than their male counterparts. And the reason that they do is because, well, they have atypical symptoms and they come in later and they're bad patients, they don't come when they're first sick, and there were a whole long laundry list of why women did worse than their male counterparts with cardiac surgery. One author went back to such a paper, reanalyzed the data, and corrected for transfusion. And the difference was the transfusion. And once you removed that and compared men and women who were not transfused, the outcomes were the same. So we've probably observed the effect of transfusion in that setting for at least 25 years, but are only now understanding that the difference has nothing to do with the symptoms or the state of disease or how good a patient you have. It has everything to do with the transfusion practice, which is different in the two groups. Okay. So what Rao found was, after adjusting for all their variables, the hazard ratio for an MI was almost threefold if you got transfused, and of death was about fourfold. And then they had a little sort of detail behind that, which is if you gave your transfusion when the patient was pretty anemic, like nadir hematocrit was 20 or 25, you had a higher rate of death, but it wasn't astronomical. But if you only let them get, say, to 30, you were incurring 168-fold risk of death, or 35, a 291-fold. This is also a repeating theme, that it's not just did you give blood, but how anemic was the patient at the time of transfusion? Sort of how indicated was the transfusion relative to the risk of the transfusion, what were the benefits? And that's a function of the hemoglobin at which you give the blood. We may look at another study, I can't remember if it's in here or not, that shows that again. So in their hands, blood transfusion in acute coronary syndrome patients was associated with an increased short-term mortality, and it persisted despite corrections. And they basically say, it looks as if you're buying your patient an increased likelihood of proceeding to an MI and dying if they come in with acute coronary syndrome and you transfuse them when their hemoglobin is over about 20, or their hematocrit is over about 20. That's a hemoglobin of 7. Okay, interesting. So transfusion associated with increased short-term mortality in medical patients and surgical patients. Well, you need to stop me now because you said, come on, don't be a putz. Just because something's associated doesn't mean it's cause and effect. We make this mistake all the time in medicine. People make it in the general population with the news, the latest of, the effects of vitamin E or whatever. We do this all the time. We mistake an association for cause and effect. And so maybe all that's happening here is that there's a cofactor, like anemia, that leads to transfusion and also leads to these really bad outcomes. And so we're seeing the association of the transfusion with the bad outcome, but the culprit is not the blood transfusion. The culprit is that cofactor that drives both of those things. Well, how do you examine that? Statisticians examine it very specifically, numerically. They ask questions like, well, if you don't have the cofactor, but you get transfused,